Hello and welcome to the Sepsis and Kids Forum that's being hosted by the Perth Children's Hospital. Tonight we've got some amazing guests for you. We've got Natalie and Christopher to talk to you about sepsis and what we're doing at Perth Children's Hospital and how we're interacting with other hospitals across Australia. But first, if I can do a acknowledgement of country. Sorry, it's not letting me control this. So just to acknowledge our traditional owners of the land on which we work and play, and pay our respects to our elders past, present and emerging. And just to take a moment to consider how lucky we are here in Perth, and in the lovely country that we are lucky enough to call our homes. I'm going to introduce Chris Blythe. He's an infectious disease consultant at Perth Children's Hospital, a clinical microbiologist with Path West. He's a professor. He is the man who can do everything, I think, and we are very lucky to have him here today. And then following that will be Natalie Middleton. And if Chris is the man that can do everything, Natalie is definitely the woman. She has been working on our sepsis program here at Perth Children's Hospital, and we've been very lucky to have her here. So without further ado, I'd like to encourage Chris to come and talk to us about what sepsis is.
Thanks very much, Hayley, and thank you for the invitation and the opportunity to talk to this audience. I'm going to give a little bit of a brief introduction to sepsis and also answer some of the questions that have been provided by audience members before this, and then hand to Natalie, but also very much keen to try and answer as many questions as we can tonight. So if I could go to the next slide, Hayley. Importantly, there's lots of words that are often used throughout describing sepsis in the community or by healthcare professionals. They're often descriptive words like sepsis or septic shock, toxic, septicemia, bacteremia, or sometimes even represent the pathogens, the germs, the bacteria that drive sepsis, like meningococcal, streptococcal. But so they're all on the same page. I want to define what we're talking about, and I am going to use some medical language, but then try and explain that. If you go to the next slide, Hayley. So sepsis really is a dysregulated, in other words, an abnormal response to an infection that really leads to the body's organs and organ dysfunction. So the organs really not working. So a couple of important things. It is an abnormal response to infection. It's where that response drives much of the damage that occurs, and it is something that is rapidly progressive and requires urgent treatment in hospital. And unfortunately, sepsis is one of the things that can lead on to septic shock, where your blood pressure drops very low and subsequent organ failure. And so importantly, if it's not diagnosed and treated early, unfortunately, it can be severe and it can be fatal. Next slide. So it's importantly, if sepsis is being considered, clearly there are interventions that we want to introduce, and time is key here. Timeliness is very important as far as the treatments that we can offer in somebody who is septic. Next slide, Hayley. The question is, what can cause sepsis? And if you go to the next slide, it can be caused by a number of pathogens. So bacteria are the major drivers of sepsis, but we do see viruses sometimes driving sepsis, including in very young babies. In specific populations, particularly the young and those whose immune systems don't work well, fungi, environmental fungi, can sometimes drive sepsis, and it can be a combination. But the important point is sometimes we don't know or cannot identify the pathogen that is driving sepsis. So sepsis is a clinical picture. It doesn't have to have a particular germ associated with us. Next slide, Hayley. My next question I'm going to cover is, how common is sepsis? If you could go to the next slide. So if you look globally, There are many millions of cases of sepsis, and unfortunately, children are overrepresented in that. There's estimated to be about 50 million cases of sepsis each year, and about 20 million of those cases are in children. And it is estimated that about 2.9 million deaths occur from sepsis in the under 5 age group. If you look at the plot that I've got on the right-hand side of this slide, I put this to highlight actually sepsis occurs at the extremes of age, much more common in the very young, increasingly common in the elderly, with relatively low rates in the middle. But importantly, it occurs at all ages. So anyone is susceptible to sepsis. If we think about what happens in the Australian context, there's thought to be about 50,000 cases of sepsis across Australia each year. And if it boils down to it, it means that about 50 children die from sepsis each year in Australia. Next slide. So at PCH, we've been looking hard at sepsis for a number of years now. And to put things into perspective about how common it is, we see about 10 patients per week at our hospital with suspected sepsis, and that includes about 2 that go to the intensive care unit. The reason I put these figures up is twofold. We have thousands of patients who present to our hospital every week. So, compared to the thousands of children who present, sepsis is relatively uncommon, which is really one of the challenges. It's actually trying to pick the child who has sepsis from many of the other conditions that children present to hospital, many of the conditions that can cause temperature and some of the symptoms that we see with sepsis. As I highlighted before, anyone can get sepsis, but we particularly see it in the very young children, children whose immune systems don't work as well as they should do, some children with chronic medical conditions, and there are population groups, including Aboriginal children, that are increased risk of sepsis compared to other children. Next slide, if I can, Hayley. Now, I realised I've got a question before that I will just go back to now. One of the questions that was posed about, what are the common causes of sepsis? Is it strep throat or appendicitis in different age groups? I think it's important to highlight actually the causes for sepsis varies by age. For example, the bacteria that live at the back of the throat, the streptococcal bacteria, is actually a common cause of sepsis in young children. In fact, one of our most common causes of sepsis, where intra-abdominal infections like appendicitis are a much more common cause of sepsis in adults and the elderly. So the causes of sepsis depends on your age. Now, this question is, does sepsis occur more often in children than in adults? Well, I think my plot that showed the very young children are at particular risk and the elderly answers this question. And the last one is, what is the mortality rate of sepsis? Actually, this is a really hard one because it depends on how we define sepsis. But the mortality rate of sepsis is of the order of a couple of percent, even up to 10%. So importantly, it's something that we do want to detect early because of the harms associated with that. Next slide,
Chris,
if I could, Hayley.
I wonder if you'd just be able to explain what mortality rate is in case everyone doesn't work in hospitals or
Great.
research.
Yeah, great. So mortality is death. So what is the number of people who die from sepsis compared to all of those who have sepsis? And the reason that's actually hard to give a number, it depends on the context. It depends on what sort of country or place you live in, how well sepsis is recognised. Thankfully, in Australia, the mortality rate from sepsis is low compared to what we observe globally at this stage. But importantly, that's because we're increasingly recognising sepsis. We do a lot to try and make sure that someone coming through our front door of our hospital is screened for sepsis. And importantly, we have many of the treatments that may not be available in other parts of the world. So thankfully, the mortality rate in the Australian context and at our hospital is incredibly low, but it's not zero, which is part of the reason that we need to continue with our efforts to recognise and treat sepsis early. Okay, it's great. That's a great lead into what are the signs and symptoms of sepsis. If you could go to our next slide. So let's step through these. So could it be sepsis is the question that we ask all our clinicians to question themselves every time they see a child. And things that would make us question about sepsis is, do they have a very high temperature or a very low temperature? Are they breathing much more rapidly than we expect? Is their skin cold or mottled or even bright red and discolored? Do they have a rash, which we call petechiae, which is lots of little bruises underneath the skin that doesn't fade when it's pressed? Sometimes septic children present with drowsiness, confusion, irritability, and difficulty awake, and sometimes they're just restless or floppy, uncomfortable. Just next. Sometimes they present with pain, particularly if they've got a part of their body that is infected, but actually sometimes with patients with sepsis just feel pain all over, so unwilling or unable to walk. Sometimes, either due to infection of the brain or due to the metabolic complications of sepsis, they may present with fits or seizures. So that is one of the other signs. And I mentioned this before, severe pain is actually particularly notable in those with severe sepsis. We also know that those children who are septic are often difficulty keeping their fluids down, so they may be vomiting, they may be unable to drink, they may be passing less urine or have less wet nappies because they're not perfusing, they're not getting as much blood to their kidneys. And so I think it's important to highlight there's a constellation of possible symptoms that sepsis can present at. Usually they are changing rapidly, and usually more than one of these symptoms is present. But when early, one of these symptoms can present in isolation. Next slide, if I can. So, what are the signs to look out for sepsis? Was one of the questions that was posed to us. I've walked you through that. There's a couple of important things. One, it's usually these symptoms are progressive. And I think it's important to highlight, if you are worried as a parent, this is something to listen to you about. And if you're worried that your child is more unwell than they normally are or progressing rapidly, it's important to trust yourself. So, lots of questions about fever. Actually, fever in itself is not a dangerous thing. Fever is part of the body's normal response to an infection. So, I'm not so worried about the fever or a specific number. Um, it's these other symptoms that make me more worried about that. Should we give Panadol for a fever? Well, importantly, paracetamol does drop your temperature a little, but if your child is well with a fever, there's not a great reason to have paracetamol. Fever's not dangerous in itself. Panadol is very useful for symptoms such as pain, and importantly, if they're irritable with the temperature. I suppose I'm trying to highlight that temperature is not something to be feared, it's the other constellations of symptoms that are more important. And we had a question about diagnostic tests. So, is there a special test that we can use to identify children with sepsis early? There's been incredible work to try and answer these questions over many years, and there are some tests that are useful to identify those who are more likely to have severe infection than not. But you know what? There's not a single test that is the only test we use in those looking for sepsis. We use a combination of what the child looks like, what they're acting like, what their risk factors are, and some of their tests can assist with that. But unfortunately, we don't have a single test. Now, I am going to hand to Nat to talk about our sepsis program at PCH.
Thanks, Chris. Hello, everybody. Thank you for making the time to join us tonight. So, Perth Children's Hospital has made sepsis recognition and management a clinical and health service priority. We're one of the first hospitals in Australia that have a dedicated sepsis program. We're dedicated staff. So myself, I am the sepsis nurse at Perth Children's Hospital, and we also have a dedicated doctor who works part-time as the sepsis medical lead at Perth Children's Hospital, Dr. Bernard McCarthy, and he is also an emergency physician. So why do hospitals need a sepsis program? For one, in June of 2022, the Sepsis Clinical Care Standard was released by the Australian Commission on Safety and Quality in Healthcare, and its intention was to ensure that patients presenting with signs and symptoms of sepsis receive prompt, optimal clinical care from onset to discharge from hospital into the community. This includes timely recognition of sepsis, early and appropriate antimicrobial therapy, which is antibiotic treatment, and then the continuity of care from the acute hospital into the community through their discharge and recovery. So that's clinical care standard and its intention. That really forms the foundation for our sepsis program here at Perth Children's Hospital. So we also, along with Bernard and myself, there is a group of clinicians at Perth Children's Hospital, and they are integral in guiding the direction and the priorities of the sepsis program. And that group, we're very lucky to be led and chaired by Dr. Abide Chris. Additionally to that, not added on this list, but equally as important is we have a group of consumers. These are mums and dads who have had children who have been affected by sepsis, and they also provide us with invaluable direction and feedback for the priorities of the program. Just so you know as well, there are also other statewide, so WA-wide sepsis group, and also other national Australian-wide sepsis groups who are all working together to learn more and about sepsis, in particularly by directing priorities in research relating to paediatric sepsis, but also to learn from each other to best implement the objectives of that clinical care standard. Thank you, Hayley. The next slide, please. So at PCH, we've worked with a large team of clinical experts to develop some key resources for our staff at the hospital and some key processes at the hospital. That includes a sepsis pathway, and that's a system to detect and manage patients with sepsis. In addition to that, we've developed education resources for staff and patients and families about sepsis, and our priority is to increase community awareness of sepsis to help with early recognition and prompt treatment of sepsis. Next slide, please. So what happens after your child potentially is diagnosed with sepsis? They'll receive care by the teams at Perth Children's Hospital, and this could include care by the Paediatric Intensive Care Unit team, infectious diseases teams, general paediatricians, the surgical teams, dietitians, pharmacists, social work, to name just a few of the teams working together to care for the patients at Perth Children's Hospital. And there is a condition called post-sepsis syndrome. This condition is described in the adult literature and the adult research. However, we know very little about this in paediatrics. We do know that sepsis affects many organs in the body and that it affects everyone differently. For example, after an episode of sepsis, a patient is more likely to pick up infections. We do know that some parents talk about their child's challenges in getting back to school and play. And we do know that mums and dads we speak to also talk of their experiences watching their child deteriorate and then recover from sepsis, and how this can be very difficult. So learning more about post-sepsis syndrome and doing research about our care of patients as they transition home and are there discharged from the hospital is a priority of the Perth Children's Hospital Sepsis Program. And I'll hand it over to Chris to talk about the particular research program we have got this year.
Thanks very much, Nat. And it's important to highlight that our consumers have really led this program. They've identified the challenges in transitioning from hospital to home in the setting of sepsis. And so we're really trying to devise a program that can support our families with that transition. So through interviews with families and focus groups, literature search, we're developing a platform that allows us to ease that transition for families and expect to launch that platform at the end of this year and really look forward to evaluating that next year and importantly rolling it out to other sites apart from Perth Children's Hospital, really to focus on actually how do we help those families make the transition to home and make sure that their children are supported in their post-sepsis journey. Next slide if I can. So importantly, if you would like to participate in this, would love you to be involved. We're very keen for consumers and community members to be involved with this program. And so there'll be a survey after tonight's forum if you are willing to be involved. We would love to have your insights, particularly if you have had experience of sepsis or a family member has had experience of sepsis, to try and devise this novel but importantly supportive program for our families. Ellie.
We've actually got a video at the end. We are able to actually host any more questions. If you've got any questions that you would like to ask of Natalie or Chris, then please do jot them down in either the chat or the Q&A function. And we will try to respond to as many of those as possible. But we thought it would be good to listen to Megan's story so that you can really understand the impact of the whole work that our team here are doing.
Every family's experience of sepsis is different. We'd like to share some of their journeys with you.
My daughter Megan became unwell in November last year. I remember it was around Halloween actually, and we had to sit out the trick or treat because both her brother and herself were sick. Just sort of had cold-like symptoms. Megan in particular was running a temperature, but it was nothing different to what we dealt with in the past. It just sort of extended into a fourth day, and just sort of the instincts kicked in at that point, and we just thought, gosh, this is something different that we're dealing with, that she needs to go to ED. But I mean, the night before that she went to hospital, she was actually dancing around really happy, like you wouldn't have known that it was as serious as it was. I think what really prompted us to take her to ED was that we saw a change in her condition that morning. So she had pain in her chest. She started going floppy. She was okay in the car. She was sitting up. I drove her there. She actually walked herself into the emergency department. The whole time in my head I was thinking they're going to turn us around. They'll be like, she's just got a cold, like just, you know, fever, she'd just go home sort of thing. We saw the doctor, and then really from there she just sort of started to go downhill when she was being examined.
Your daughter's very sick. She's very sick. There was no, and you're sort of waiting, yeah, but she'll be okay. So there was no but.
So we still didn't know at that point that she had sepsis. We didn't find that out until when we got upstairs. Yeah, I just remember one of the consultants showing me the scan of her lungs. The consultant said she's the sickest child. She was in a coma, I think, for about 6 days. In ICU for 12 days. We went into a ward after that for 10 days, and we were in the hospital for a total of 3 weeks.
It's scary. I guess you know that she's in the right spot as well. I mean, it's scary, but it's also comforting in a way that you know that they've escalated it so quickly. They're all very aware of the signs and listening and what we thought. They were very keen to hear what we thought about where she was, how sick she was, and her condition. So I think that's also played a part in how quickly and how well she come back from it.
Trust your instincts completely. Just, you know, if something's wrong and something's not right, just, you know, you've got to trust your instincts and take your child to ED.
I think most parents are always concerned that they don't want to be the one that overreacts and takes their child in when they're not really sick. You know when something's wrong. You don't need to diagnose, but you know there's something different.
It's so amazing to see it now, but it was such a traumatic time.
Everyone's experience of sepsis is very different. If you'd like to learn more about sepsis, please visit our website. Every family's experience of sepsis is.
And I'm just going to stop sharing now. So I can't see any questions in the chat function or in the Q&A, but I know I'm getting a little bit glitchy here. So the joys of technology. So I think, Natalie, just talking about while we're waiting to see if anyone else is got any questions on here, but I'm just thinking about the consumer group that you want to actually establish. What are the sort of people that you're looking for? What is it that a lot of people will sit there and think, I don't know things. You guys have got all of the qualifications, all of the experience. What is it that you're really needing from parents and carers of children who have had sepsis?
No, that's a great question. Thank you, Hayley. So we're very keen to hear about your experiences, and particularly after discharge home. What services in the community you might potentially would access after you've been discharged home from hospital, and in particularly doctors, nurses, allied health in the community. And is there the resourcing in the community? Is there for those health professionals to provide you the support that you need after your child has been discharged home following a diagnosis of sepsis? And what we do hear from our families and that we have already spoken to is that when you're in hospital, you're in that fight or flight mode. You get so much information. It's incredibly stressful. And then you're discharged home. And at that point, then you're by yourself. You've had some time to reflect, but there's no one to ask those questions to that come up. And we're very keen to create resources for those particular families to answer those questions that may come up, and also is there a person that they could contact, in particular if they're struggling after they've been discharged home.
That's fantastic. I'm definitely one of those people who gets home and thinks of all the questions. So I would totally be one of your patients. And Chris, I just wonder, as we haven't had any different questions through yet, whether you can describe what post-sepsis shock is in the adult world. How do you determine what post-sepsis shock is?
So I suppose post-sepsis syndrome in adults are a constellation of symptoms that can be ongoing physical complaints, such as pain or difficulty doing things. Some people with post-sepsis syndrome describe more cognitive changes or behavioural changes or mood changes. So it's a constellation of challenges that occur in somebody that has sepsis. In fact, we've recently done some work looking at adolescents who've had invasive meningococcal disease, one of the causes of sepsis, and they have higher rates of mood disorders, so depression, post-traumatic stress disorder, anxiety after their episode compared to other adolescents of the same age. So it can be a number of symptoms and signs, and often it can linger, and to be truthful, often it remains undiagnosed for a long period of time. I suppose I'm going to answer your next question. What does that look like in children? We know much less about this in children than we do in adults, particularly non-verbal children. But we suspect challenges when it comes to school, behavioural challenges, but importantly, this is an area of research that's really important. Our families describe the challenges that they have when they get home, and so it's an area that we do need to do further research to understand how best to support that child and that family.
I can understand it would be very hard in the children's setting. What is part of their development compared to what's been caused by the sepsis would be really hard. As a parent myself, I constantly question things. So I'm sure a lot of other parents out there can identify with that. I'd like to say a big, big thank you to Christopher and to Natalie for coming and sharing some of their experience, some of their wisdom, and talking about the programs that they're doing. But also to say thank you to every single person who has joined this evening. We had some great questions sent through, and it really helped to share what we've actually talked with you about today. So thank you very much, and we will be in contact with you all, and we'll also send that link to anyone who couldn't make it today. Thank you. Goodbye.